Esteemed veterinary colleagues, a warm welcome to another insightful episode of our podcast, Feline Perfect. Today, we delve into a particularly challenging and frequently encountered condition in feline medicine, Feline Chronic Gingivostomatitis, or FCGS. Our focus will be on unraveling the complexities of its diagnosis and exploring the most current and effective therapeutic strategies available. Understanding FCGS more than just a sore mouth. FCGS stands out as an exceptionally debilitating inflammatory condition affecting the oral cavity of cats, with reported incidence rates varying from 7% to as high as 26%, depending on geographical location and study populations. This variability underscores the importance of understanding local risk factors and prevalence. The discomfort and pain experienced by these feline patients are substantial, significantly impacting their quality of life. It is defined by a multifactorial etiology, necessitating a comprehensive approach to differentiate it from other oral pathologies. Conditions such as aggressive periodontitis, contact stomatitis, eosinophilic granuloma complex, and critically, oral neoplasia, particularly squamous cell carcinoma, can mimic FCGS, demanding meticulous diagnostic precision, the oral cavity, a delicate balance. To truly grasp the pathology of FCGS, it's essential to appreciate the physiology of a healthy feline oral cavity. The oral epithelium serves as the body's first line of defense. This multi-layered physical barrier is in a state of continuous renewal, shedding cells and regenerating in approximately 2 weeks. Functioning as a chemical barrier, it selectively allows permeability while actively secreting defenses that are integral to the innate immune system. Saliva coating the epithelial surface plays a pivotal role, enriched with mucin and immunoglobulins. Furthermore, the commensal microbiota exists in the oral cavity in a balanced relationship with the immune system. In essence, the healthy oral cavity is dynamic, exhibiting immune tolerance. However, in FCGS, this harmonious balance is disrupted. The imbalance unveiled. Immunopathology of FCGS. When an external agent breaches the oral mucosa, antigen-presenting cells capture the intruder, migrating to inductive sites like tonsils and lymph nodes. There, they activate lymphocytes, which then travel back to the inflammation site to mediate the immune response. In healthy cats, dendritic cells and CD4-GA1 T helper cells predominate in the gingiva. However, in FCGS, this immune response is significantly altered. Histopathological evaluations reveal lymphoplasmacytic inflammation with neutrophils evident in areas of ulceration. Immunohistochemistry shows T cells infiltrating the epithelium, while B cells remain restricted to the submucosa. Interestingly, in edentulous cats, there is no significant difference in the quantity between CD4-GA1 and CD8-GA1 T cells. Mast cell densities are significantly increased compared to healthy controls. The local cytokine expression shifts from a predominantly Th1 immune response associated with health to a mixed Th1, Th2 response. This shift is crucial, and positive correlations have been noted between disease severity and specific cytokines and immune receptors that recognize pathogens like feline calicivirus and T. forsythia. The microbiome shifts to disease-associated populations, with the host responding by combating intracellular organisms. Systemic changes mirror these local disturbances, including alterations in cytokines, hyperglobulinemia in approximately 60% of patients, anemia, and neutrophilia. An increase in CD8-GA1 memory cells and a reduction in central memory cells suggest unresolved inflammation, and chronic antigenic stimulation. Chronic viral infections, particularly with feline calicivirus and feline fomivirus co-infection, are associated with a lack of treatment response, retroviral status, especially FIV positive patients, carries prognostic significance. Recent evaluations of RNA expression in affected tissues suggest a possible genetic component to this disease, with upregulation of IL-6, IL-7A, and myeloid lineage enrichment. Diagnostic strategies. A multifaceted approach. A thorough diagnostic approach is paramount. Patient history, anamnesis, or inquire about lifestyle and environmental factors. Cats in shared households have a sevenfold increased risk. Or note any history of blood-tinged or yellow saliva, difficulty eating, and previous unsuccessful periodontal treatments. Physical examination. Or look for oral discharge, halitosis, enlarged mandibular lymph nodes, poor body condition, matted hair coat, and pain upon opening the mouth. Oral examination. O. Observe gingivitis extending beyond the gingival margin and affecting the alveolar mucosa, or identify ulcerative or proliferative inflammation. FCGS rarely affects the palatal mucosa, aiding in differential diagnosis. Complementary diagnostics will perform pre-anesthetic evaluations and viral testing. Feline calicivirus, retroviruses, or incisional biopsies are strongly recommended to rule out other differential diagnoses. Outcome measurement. Or utilize objective indices such as the Stomatitis Disease Activity Index, SDAI, quality of life scales, and client-specific outcome measures. Therapeutic interventions. A stepwise approach. Effective management of FCGS requires a multi-modal strategy. Medical management. Pain control is paramount throughout all stages. All immunosuppressive medications can help approximately 45% of patients. All antibiotics may benefit around 30% of patients. Or consider proton pump inhibitors due to the prevalence of esophagitis. Surgical management or full mouth extraction remains the gold standard for generalized inflammation. All partial extractions may be considered in limited rostral cases. All post-operative radiographs are crucial to confirm the absence of retained roots. Refractory case management. Early intervention is recommended for patients unresponsive to extraction after approximately 50 days, or prioritize pain control and consider immunomodulation rather than immunosuppression to address potential T-cell dysfunction induced by chronic viral infections. Systemic support is also essential. Emerging therapies. A glimmer of hope in refractory cases. Mesenchymal stem cell MSC therapy presents a promising avenue. MSCs modulate both the innate and adaptive immune responses, acting like a Swiss Army knife for the immune system. Allogeneic MSCs from donors are preferred due to challenges in obtaining cells from diseased cats. The mechanism of action involves inhibiting excessive T lymphocyte expansion, restoring T helper cell balance, and enhancing CD8-GA1 T lymphocyte cytotoxic function. Clinical studies show a positive response rate of approximately 65.5% with adipose-derived MSCs. Side effects are generally mild and self-resolving. FCGS is a complex and challenging disease that necessitates a comprehensive understanding of its pathophysiology, coupled with a meticulous diagnostic approach. While conventional treatments like full mouth extractions offer relief for many cats, a subset remains refractory highlighting the need for innovative therapies. Mesenchymal stem cell therapy holds promise for these cases, offering a potential avenue for immunomodulation and improved clinical outcomes. Further research is crucial to refine our understanding of FCGS and optimize therapeutic strategies, ensuring the best possible care for our feline patient. Thank you for your attention.